I wasn't excited about the last one because I dabbled in a little bit of epilepsy here in San Antonio, and he has Dr. Parnes will be speaking to us on movement disorders, and he has several, I'm sure there will be interesting video clips or DVD clips or USB clips, whatever clips they are these days. Okay, Dr. Parnes is yet another Baylor College of Medicine employee. And when I introduced myself, I actually, in full disclosure, I work here at the Children's Hospital of San Antonio, but I'm also a Baylor College of Medicine Houston employee. Now, Dr. Parnes, I think, is also from the Northeast. He did his undergraduate at the Drexel University, and actually, sorry, medical school at Drexel University. Here I was yesterday, this poor Malaysian Australian boy. I'd have to Google some of these places to know where they were in this fine country of ours. Yes, medical school, Drexel, Philadelphia, and then he did his pediatrics residency in SUNY Downstate Medical Center and came down to Baylor College of Medicine, Houston, to do his child neurology residency. He then completed one of the handful of movement disorders fellowship-trained child neurologists in this country, which, without being too pro-American, I think you can safely say in the world, one of the handful with a full movement disorders fellowship. He's currently the director of movement disorders at Texas Children's Hospital, where he's an assistant professor, and his interest areas include, as you would expect, Tourette syndrome, GLUT1 deficiency, and Wilson disease. I'm not saying 2 or 3 of his other interest areas because I don't really know how to say or spell them. Without further ado, I will introduce Dr. Parnes, who will be speaking to us on wiggles, shimmies, and shakes, a review of pediatric movement disorders.
Morning, everybody. Do you folks notice that when Dr. Ng says anything, really, it just sounds so much better? It's like just so well enunciated and beautiful. Anyhow, so we're gonna have some fun. I know it's early, but I'm gonna show you some videos as he mentioned. So my goal for today is to run through how we view and classify and talk about and identify movement disorders, and in particular pediatric movement disorders, and have you walk out of this room with some knowledge that perhaps you didn't have before. If I may, how many of you in the room feel very confident and comfortable with identification and treatment of movement disorders? We got one. Okay, all right. Okay, terrific. So this is going to be great, I hope, maybe, hopefully. Yeah, Dr. Emmerich office is next to mine. I don't have any disclosures. So first thing to do is to talk about how we classify these things. So we talk about them being, if you have too much movement, if you have an excess of unwanted movement, we call those hyperkinetic movement disorders, so literally hyperkinetic, too much movement. And these disorders listed here are types of hyperkinetic movements. And that's the vast majority of pediatric movement disorders. Then we have a paucity of desired movement, so we call those hypokinetic movement disorders. You're not moving enough. The movement disorder in this category is Parkinsonism, and the most common cause of Parkinsonism in the adult population, is, as you know, is Parkinson's disease. And then you have other stuff. So other stuff tends to be ataxia, and classically that's fallen under the movement disorders rubric as well. So those are the 3 areas of classification that we're working with. When we talk about abnormal movements, we describe them in terms of what we call phenomenology. Phenomenology is analogous to semiology when we talk about seizures. It really means the same kind of thing. So it's the language that we use to discuss and talk about what we see when the actual event happens. And we use a lot of words with particular connotations to try and communicate with each other what we saw. So some of these words I'm listing here. So are these movements rhythmic? Are they continual or are they intermittent? Do they happen in paroxysms? Are they patterned or are they not patterned? Are they predictable or is each movement recognizable? Do they happen suddenly or quickly or are they slow? Are they jerk-like or shock-like? Do they flow from one part of the body to another? And are there abnormal postures or twisting, and are they sustained or are they not sustained? And then we talk about the body parts or muscle groups that are involved. So that's what we're going to be doing. So if I may, I'd like to invite you to be recruited into screaming and yelling phenomenology terms as we look at some of these videos, okay? So I'm counting on you because otherwise this is going to be a very dull lecture and it's very early in the morning. All right, so this is a 3-year-old typically developing male who had involuntary movements beginning at 12 months of age. So if you would, any of those words we were just talking about to describe the phenomenology are welcome, or if you want to just tell me what this is, what is this? You could tell me in as common language terms as you like. What's this guy doing?
And it's mommy.
Yeah, he's got an action tremor. Okay, yeah, pretty specific. So he's shaking, right?
Okay.
Yeah, and my colleague over there recognizes that he is only shaking when he's moving. He's not shaking at rest. And a lot of this, of course, is going to come from the history as well. So what he has is tremor. Tremor is an involuntary, rhythmic, oscillatory movement about a joint axis. And we talk about tremor, as was pointed out, by the situations when we see it. So if you have tremor when you're just sitting still and you're not holding a posture against gravity, you're just at rest, then we call that a rest tremor or a resting tremor. If you have tremor when you elevate your limbs against gravity and hold them there, then we call that a postural tremor. And if you see tremor when you reach for something or when you're voluntarily moving, we call that a kinetic tremor. And action tremor and kinetic tremor, which commonly occur together, when we put them together, we call them action tremor. Okay, kinetic tremor and postural tremor. When we put them together, we call them action tremor. And then there's this word intention tremor, which gets thrown around a lot, and frequently people, I think most commonly when people say intention tremor, they mean action tremor or kinetic tremor. So intention tremor has the connotation of worsening as as the body part approaches the target, it worsens. That's intention tremor, and it's thought about. We think about cerebellar tremor when we when movement disorders people hear intention tremor. So otherwise it's really an action tremor. So those are those things that we had just mentioned. So very rarely in pediatric movement disorders are we going to see rest tremor. It's mostly going to be action tremor. And here's what I think is a reasonable differential for tremor in childhood. So up at the top there is essential tremor, which I'll say more about in a second. There's also dystonic tremor, which even in adults can look quite a bit like essential tremor. But dystonic tremor is a tremor associated with dystonia, which I'll talk about a little bit later. And it tends to be more irregular, and it may have a positional component. So you may shake more, for example, when you supinate your forearm, and less when you pronate your forearm. So that sort of a thing, it tends to, the amplitude of the tremor worsens as you bring it away from the direction that the dystonia is trying to pull the limb. So if you see a positional component with the tremor, it happens when I am doing X, but not when I'm holding my arm this way, then it might suggest a dystonic tremor. In pediatrics, we see drug-induced tremor as well as in adulthood. So some of the medications that commonly cause drug-induced tremor are listed here. So in particular, adrenergic agonists. So in kids, we're using ADHD medications, asthma medications. A lot of the immunosuppressants can cause tremors, in particular corticosteroids. The anti-epileptics, Depakote, is famous to cause an action tremor, and some anti-arrhythmics like amiodarone, and some antidepressants as well. And lithium also is very well known to cause tremor. You can see tremor associated with metabolic derangements like hyperthyroidism and hypoglycemia. I tend to check thyroid a lot when I see otherwise healthy teenager, for example, who presents with tremor, who doesn't have a strong family history, but I haven't been running across a whole lot of it, but I do check. And then you can see tremor associated with a number of different genetic disorders. So the cerebellar syndromes frequently have tremor, and then other genetic syndromes also are known often to have tremor, like Angelman tremor. Angelman syndrome has a very particular tremor associated. And you can see tremor, of course, in psychogenic movement disorder. So essential tremor, as you may know, is an action tremor. In other words, a postural and kinetic tremor. And it most classically affects the bilateral upper extremities, but it can also affect the head, and can affect the voice. These children, when they present, and if you're wondering about essential tremor, they should otherwise have a typical exam. They should have normal development. We know that in adults, and this is a conservative estimate, we think that about 5% of adults age 65 or older have essential tremor, and we know that it is, in terms of the inheritance pattern, it's an autosomal dominant and highly penetrant inheritance pattern, but we don't know the gene, despite lots and lots of looking. We don't really know too much about how many kids have essential tremor. But we know that if we talk to adults and we ask them about when their essential tremor presented, that oftentimes, certainly in adolescence and 20s, a lot of adults recall having tremor that early, and some recall having tremor in childhood. Typically, we think of it as occurring maybe in the second decade, but I am seeing these patients who, at least at the moment, really appear to have essential tremor, and they have a very, very strong family history of essential tremor, which kind of helps you be more confident in making that diagnosis in a small child with an otherwise normal developmental history and exam and a normal neurologic non-focal exam. May get worse with advancing age, and there are treatments for essential tremor that can be very, very helpful. Typically, we start with propranolol, just like we do in adults. I'm just curious, by show of hands, how many adult neurologists have we got in the room? Okay, whole bunch. Okay, awesome. And then are the rest pediatric neurologists? How many pediatric neurologists? All right. Okay, cool. All right, so we've got, next up, we've got a 14-year-old, normal cognition, involuntary movements since before 12 months of age.
All right, tell me why you're here.
All right, so.
Oh yeah, you were telling some jokes. Tell me another joke.
Continual, intermittent, is it, what kinds of words would you use to describe what he's doing? I heard athetoid CP, I heard dystonic tremor.
There you go.
Anybody else?
Good, and your chin? Good.
I don't see too much tremor.
I did see that. I was going to let you off the hook, but you
I don't see
pointed it
too
out.
much
Okay, your chin
athetosis.
again.
I'm not being critical.
Okay, very
If I make anyone feel bad, like I'm a pediatric neurologist, I'll come hug you later. Do you notice that he has some twisting, abnormal postures that are sustained for short periods of time and then remit? What has he got? Dystonia, yeah. All right, so dystonia. So involuntary, sustained, or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. This has been defined and redefined, and you'll notice that this language appears maybe a little bit stilted, but, committees. So this is, so typically pattern twisting may be tremulous, so it may have associated dystonic tremor. Often initiated or worsened by voluntary action and associated with overflow muscle activation. So did you notice that he looked okay until he started talking, and then boom, So we tend to see that, or with voluntary movement, then these involuntary movements get triggered. They go to shake your hand and their leg kicks out, stuff like that. It's can be associated with overflow muscle activation, so they can have poor isolation of the muscles that they're trying to voluntarily use, and the muscle groups around it may also stiffen up. And we can describe it in terms of the body parts involved in terms of being focal, so you can have, the most common focal dystonia is writer's cramp, so that's of the muscles of the forearm, and it's what we call a task-specific dystonia, so writer's cramp starts just when you're writing, otherwise you don't have any dystonia. You can have multifocal, so maybe an arm and a leg on the opposite side, for example. You can have segmental dystonia with muscle groups that are adjacent, or hemidystonia. So when we talk about dystonia, there are what we call isolated dystonias, which until 2014 were called primary dystonia and have been reclassified. So the isolated dystonias are kind of pure phenotypes that are thought to be monogenic and have a typical natural history. So they're similar to the idiopathic, do we still call them idiopathic epilepsies? Depends. Genetic epilepsies, if you like the 2010 reclassification. Anyhow, so you can think of them in that way, that they have a particular age of onset and course. For example, DYT1, which is the most common form, tends to occur initially in one lower extremity and then spread to the other lower extremity and then generalize. So some of these syndromes also have other involuntary movements, but they're still very characteristic. So we call those the combined dystonia syndromes. We used to call them the dystonia plus syndromes. And these are the DYTs. So DYT1, DYT6, DYT11, et cetera. Most common forms are DYT1 and DYT6. So here are this is our knowledge to date, as of 2014 anyway, this review of all of the DYT classified isolated dystonias. And then we have secondary dystonia. So in my clinic, overwhelmingly, in the pediatric population, what I see is secondary dystonia. These are kids who had perinatal HIE, they have metabolic and genetic disorders, they had herpes encephalitis, they had abusive head trauma, and then they have secondary, usually not pure dystonia. They usually have, they may have microcephaly and blindness and intellectual disability, and they may have spasticity. If they have genetic disorders, they may have dysmorphic features, and it tends to be generalized, and it tends to be very difficult to treat. So if you're going to try to treat dystonia in my population, and I would think even maybe in adults, depending on what you're seeing. I mean, probably not if they present in their 50s with cervical dystonia. But all children who have dystonia deserve a trial of levodopa because there are these 3 known congenital enzyme deficiencies that result in the dopa-responsive dystonia phenotype. And these kids, I just saw one of them the other day. He's a 17-year-old child who, when he was 4, started to have marked dystonia, started in one limb, generalized, and then he went maybe 5 or 6 months where he couldn't walk. And he was totally, upper and lower extremities were profoundly affected. And then somebody thought to give him a little bit of Cinemet, and bang. I mean, he had 1/2 tablet of carbidopa levodopa 25-100 at bedtime and woke up normal. So just to stress that everybody deserves a trial. That said, if it's not dopa-responsive dystonia, the likelihood that it's really going to do something dramatic is very small. And then here are the other medications that we use. So we try benzos, particular clonazepam, Artane, or trihexyphenidyl. We use oral baclofen. If there are particular functional goals, if this child has generalized dystonia but an intellectual disability, let's say, but boy, if he could get a Cheerio into his mouth by himself, that would make a huge improvement and functional difference in his life, then we may try things like Botox injections in that limb. Intrathecal baclofen also probably is one of the most helpful things, if need be and if appropriate, can be helpful in that secondary dystonia population. And you can think about deep brain stimulation of the globus pallidus internus, but in the secondary dystonia population, it's not going to be as effective. It's been studied in DYT1, one of the most common isolated dystonia, and it works really well. Tends to work very well. All right, 5-year-old male with history of neonatal hypotonia, mild global developmental delay, and voluntary movements that started at age 2.
There you go.
So tell me if these things are intermittent or continual. Are they patterned? Or they
open it and keep it at
what is it that you see?
1, 2, 3. Okay. Hard to do that, huh?
He's having trouble keeping his tongue out.
Good. Come on back.
They knock him off balance.
Good. And go the other way again.
Would you show it one more time? Would you mind? Anybody know what this is? Not the disorder, but the phenomenon. What's the movement disorder that what's the classification? What do you think this guy's doing?
Yep, keep him just like that.
Is this tremor? Is it dystonia? It's Chorea. Yeah.
Open it and keep it at 1, 2,
So he has these
3. Okay.
flowing,
Hard to do that, huh?
writhing, unpredictable movements, and they're relatively subtle.
Good. Come on back.
Relatively.
Good. And go the other way again.
Okay, so this is Chorea. So Chorea is a random appearing sequence of irregular, involuntary, writhing or dance-like movements that flow unpredictably from one part of the body to another. So I actually still use this sometimes as kind of a test to see if I can tell what part of the body is going to move next. So if you just stare at them for a minute or two, and see if you can see what the next movement's going to be, then it's probably not Chorea. But if you can't, then it may be. A word about athetosis. I think this is a dumb word, my opinion. Okay, there's no literature to back up that athetosis is dumb, but it's dumb. It's just small amplitude distal chorea. So there's nothing different about its etiology, and there's nothing that's different about its treatment. So, and we see it in conjunction oftentimes with more proximal chorea too. And sometimes people call that, now you have proximal and distal chorea, well then we should say chorioathetosis. But I would suggest that we could just say chorea and everybody can just be happy. On the other hand, so you have the chorea spectrum. If you have very small amplitude distal movements, you could call that athetosis, and I'll judge you quietly. Or if you have proximal, large amplitude movements, you can call that bulismus. And it's just chorea cranked up to 10. You get these large amplitude flinging movements of the limbs. I think that that's still a useful word because I know what that phenotype means. Because those guys get bruised, moms get punched in the face when they're trying to change diapers. You can have rhabdo with sustained ballistic movements. So, it may kind of catch my attention faster. And then here's some common causes of childhood chorea. So if you do see a child, typically developing child, who had the acute or subacute onset of chorea, maybe hemichorea, certainly you'll want to look at their brain. But one of the things that you're going to want to think about with neuroimaging, but one of the things that you're going to want to think about very strongly is Sydenham chorea, and I'll talk a bit more about that in a second, which, as you know, is a symptom of rheumatic fever. One of the disorders that I'm seeing now over and over again, well, a good handful of times in the last year or two, is what traditionally has been called benign hereditary chorea, and what now we know is caused by this gene NKX2-1, and is part of the benign hereditary chorea is a form fruste of this brain-lung thyroid syndrome. So these guys can have, they can have cognitive deficits, they can have lung problems. Classically, they have, oftentimes they have pulmonary hypertension and respiratory distress for a period of weeks after a normal birth that requires intubation. And they often have hypothyroidism. So they can kind of have any piece of that. And they're at risk for thyroid and lung cancers as well. And then some of the other causes are here as well. So some of these autoimmune disorders, particularly antiphospholipid syndrome and lupus, you can see post-pump chorea. So if someone's on a cardiopulmonary bypass or they're in surgery, sometimes we can see chorea thereafter. Anti-NMDA receptor encephalitis very often has chorea as a component of their multiple involuntary movements. You can see chorea after encephalitis, and then very rarely in pediatrics do we see neuroacanthocytosis. Just a brief word about Sydenham chorea. This is the modified Jones criteria, the two most recent updates. So until recently, the most recent update was in 1992, and then again it was updated in 2015 just now. And in both of these papers, these consensus statements suggest that even without any evidence, serologic evidence, even without any history, even without a history of pharyngitis, even without a throat swab, culture, et cetera, you should suspect Sydenham chorea, which will sort of leap over Jones criteria. And think about, and I defer to Dr. Demler, but I think that it's worth at least, I'm not saying that every child who has chorea without an explained etiology needs to be on penicillin for 15 or 20 years, but I think it's something to consider, even in the absence of laboratory data. These are the medications that we typically use to treat chorea. So benzos, particularly clonazepam. You can use dopamine receptor blocking medications. I tend to use flufenazine. And dopamine depleting medications like tetrabenazine, which is approved, as you know, for Huntington's disease. 15-year-old typically developing male with history of involuntary movements from 11 years of age. This is really cool.
All right, go ahead.
Boom.
Are you able to speak?
Okay, typically developing guy, normal cognition. He has a normal baseline neurologic exam. If he stands up out of a chair too fast, boom.
Okay.
What kind of movements are those? Did you see what he did? Would you do it one more time? So he kind of stiffened up everywhere.
All right, go ahead.
What do you call what's the phenomenology of what he does? What is that? What's that look like? Jaw, he would say that his jaw feels like it pulls open. He can't move his tongue because it's too stiff. He can't talk. I heard myotonia, I heard dystonia. So yeah, it's dystonic posturing in terms of its phenomenology. And it happens all of a sudden, maybe in a paroxysm, perhaps. This happens to this guy 20, 30 times a day. And they last about 10 seconds or so, and then he goes back to normal. And they're triggered by quick movements. I'm sorry, say again? Yeah, I think you're asking, is it paroxysmal kinesogenic dyskinesia? And that's right. I congratulate you. Yeah. Yeah, and I'm going to talk more about that in just a second. Kinesogenic meaning it's generated by movement. And there are some other types that are not generated by movement. All right, so also in the realm of paroxysmal dyskinesias, here's a 10-year-old. He's typically developing, and from 12 months, he's had these longer spells. They last about 3 or 4 minutes, and they're not triggered by anything. Apologize for the quality of the video, but it took a long time for the parents to be able to capture one of these. Can you predict the next movement he's going to make? I can't. So this is chorea. Happens all by itself. 2 to 3 times a day. Lasts about 3 or 4 minutes each time. He's miserable. And I'm going to talk to you more about that in a second. So there's 4 types of these paroxysmal dyskinesias. So one, as our colleague back there pointed out, was paroxysmal kinesogenic dyskinesia. This terminology can be super scary and frightening and sort of hard to wrap your mouth around, if I may say so. But really, so they're all paroxysmal. They happen for brief periods, start abruptly, often end abruptly, and then they're dyskinesias, which is a word that just means abnormal movements. And then in the middle, you have where the money is. So you have paroxysmal kinesogenic dyskinesia. That means it's generated when you make a quick voluntary movement. So that first child, the teenager that I showed, so I walked out. We didn't have anyone to room the patients fast enough that day, so I went out into the waiting room, and I met the family, and the kid put his hand out to shake my hand, and he had one of those. And I said, I know what you have, you know? Just quick movements, boom, out of nowhere, you know? And he falls down 20 times a day at school, or he was. He'd never seen a neurologist before. He'd had that for like 5 years. And then there's paroxysmal non-kinesogenic dyskinesia. So that's what the second child had. They tend to be a little bit longer. They can be triggered by caffeine, alcohol, neither of which this patient was indulging in, or sometimes stress or fatigue. He tends to have his symptoms early in the morning or sometimes just before bed. But he doesn't have any other identified triggers. And then there are these 2 other types, paroxysmal exertion-induced dyskinesia. The latter of these 2, by the way, I still haven't seen. Exertion-induced dyskinesia, that's triggered by longer spells. So you run half a mile or you do 30 jumping jacks, and then you have one of these spells. And then there's paroxysmal hypnogenic dyskinesia, which happens at bedtime, and some people think are actually nocturnal frontal lobe epilepsy. So it's not actually clear whether these are really a separate disorder. So the most common one, thankfully, is the easiest one to treat. So PKD, the one that the first kid had. Very, very often, low doses of carbamazepine make these completely vanish. All of these disorders tend to be autosomal dominant, but they can also be, somebody in the family is always going to be first, so they can be sporadic. And the age of onset is similar, as you can see. We talked about the triggers, and we talked about the duration, and I talked about carbamazepine for PKD. I encourage you to check the HLA before looking for HLA 1502. It's a genotype that's known to have a much higher risk of Stevens-Johnson in Asian patients. So if you're going to start an Asian patient on carbamazepine, even as an adult, I would encourage you to check this, because this teenager, in fact, who is from the Philippines, it's thought to be a Han Chinese genotype. We put him in the ICU with a Stevens-Johnson rash. Okay, 8-year-old typically developing male with involuntary movements from 18 months of age. Super cute. So parents are freaked out that he's doing this.
Cupcakes, and let's see what else. Oh, we had sweet tea, and
He's got a bunch of different movements that he does.
mac and cheese, and non-purple game, and Buckle Carolyn, and who else? Let's see. Oh, Lucas and cousin Lisa, and Edith and Thomas.
Played soccer.
Thomas played soccer, and Bailey was at the bed.
Tend to happen more while he's engrossed in tasks, maybe
Because he
when he's
had surgery in his
excited.
ear,
There's
and
another one. And they're stereotyped. He has like 3 or 4 different kinds of movements that he does. Okay, I heard tics from a couple people. Here's another one. He rubs his hands together. So the hand rubbing one, and then he's got a marching one that he does together with it sometimes. Gets excited. Okay, I heard tics. Anybody else? Stereotypies. Yeah. So, right. So these are stereotypies. And, I knew people were going to say tics, and that's what people would say. I mean, a lot of people think that these are tics. So I'll tell you why they're not. So these tend to be repetitive, often continual, rhythmic movements, which can be voluntarily suppressed. So this guy has these kinds of brief runs of continual movements, hand rubbing for a few seconds at a time, or he was rubbing his nose for a few seconds at a time. Whereas tics tend to be quicker and kind of oftentimes they're myoclonic movements. These tend to be more rhythmic and continual movements. They may happen more when they're excited or nervous or while engrossed in tasks. They stop with distraction or redirection. Most importantly, even in small children, frequently they can give you this bit of history, which like it looks really cute when you ask them, but you can ask them if they like them or if they don't like them. Do these movements feel good or do they feel bad? You can ask a 4 or 5-year-old and they'll tell you that they like them, you know? Stereotypies feel good and tics feel bad. Tics, the urge to do the tic feels bad. But these, they like these. They would do these all day long. And parents will tell you, yeah, you know, how long could he do this for? Oh, 15, 20 minutes, you know, continually. That's a stereotypy. So we see these more commonly in children who have developmental differences in particular. So these are the stimming that, you know, lay people talk about stimming in autism. They're stereotypies, hand flapping, spinning in circles, things like that. And we see them most common in the autistic population, but we also see them not uncommonly in people who have cognitive deficits, intellectual disability in general, who don't have autism. And then we see them sometimes in typically developing kids like that child I just showed you. And you can talk about what parts of the body are involved, so, but often flapping, twirling, rocking, you know, trunk rocking, but they can be unusual, complex movements like this guy had. Oh, how many of you, let's say in the last 30 days, have yourself or had someone close to you have that heel tapping movement, you know, when you're sitting somewhere? Just tapping. Some of you may be bored and doing it right now. But, you know, just by show of hands, in the last month, how many of you have seen someone while they're sitting? Okay, hands are coming up. Okay. All right. So you know, that's been around for millennia, almost certainly. And until recently, it didn't have a name. But it's a stereotypy. It's the most common stereotypy in the world. And it's now called leg stereotypy disorder, which is not really a disorder, but, you know. Oftentimes, I'll explain stereotypies to parents in that way. Because they'll come in freaked. You know, that kid's family really wanted to know, you know, like, does he have Tourette syndrome? What is going on? Why does he do that, you know? So I'd say, you ever see anybody do that with they tap their heel? Yeah, okay, that's what he's got. Don't worry about it. It's fine. So, so typically they don't do anything. They're sort of maybe self-soothing, and oftentimes as kids become more self-aware as they get older, they may go away or they may do them in private but not in public. In very low-functioning children, sometimes you'll see self-injurious stereotypies like biting of the hand or head banging against the wall or, you know, punching themselves in the face or things like that. It's not common, though. So barring those situations, you can tell parents that these are benign. And medications for that reason aren't typically warranted, and they're not usually very effective. This is just another typically developing child.
Are you playing?
She has these
Can you get
twirling
it?
movements of her hands and feet.
Can
Sometimes
you
she
get it?
does it
What's
together.
inside the picnic basket?
All right. 9-month-old. Oh, also, so stereotypies tend to start or often start very young, younger than we see tics start. So parents will say they started like at 18 months, around there, like before age 2. It's not uncommon. And tics tend to happen more in school age 4, 5, 6, 7. All right, so here's a 9-month-old typically developing female with involuntary movements for 1 month. So I encourage all of my child neurology colleagues in the room not to tell your adult neurology friends what this is. So she's typically developing. She crawls over into the corner and crosses her legs, and it always looks just like that, or very similar. And she sits like that, and she rocks back and forth sometimes. And then the whole time she's just going about her business, playing with stuff. If you distract her, she'll stop. So first of all, what's the phenomenology? What category would you put that in? What is it? Is it a tic? Is it a tremor? Is it dystonia? What is it? She does it while she's busy with stuff, and if you call her name, she'll stop. It's a stereotypy, I heard. So I promise I didn't imagine it. Somebody just said it right up here really quietly. So it's a stereotypy. Anybody know what this thing is? Say again? Self-stimulation. Oh. But yeah, we got to let these guys twist a little bit. All right, so infantile gratification, we came up with a fancy name for this, infantile gratification phenomenon. Or, like our colleague back there said, self-stimulatory behavior. So we don't have to call it baby masturbation, which is what it is. Okay, so this is a benign movement disorder. You can tell parents not to freak out. It's probably going to go away. You see it in typically developing infants and young children, and it's described as, this is Jonathan Mink's description, that he said that these are typically stereotyped postures. They put pressure on the pelvis. We see it oftentimes in young girls, and they can look really funny, like they can have sweating and grunting and facial flushing and all that stuff, but they act like a stereotypy. They call their name, they stop. All right, here's a 5-year-old typically developing male with involuntary movements since 8 months of age. So are these slow? Are they fast? Are they continual? Are they persistent? Are they intermittent? Are they abrupt? Are they, what would you say? What are these things like? Fast, okay.
Good, and put them down again.
And then I heard myoclonus. I agree. Say again? Segmental myoclonus,
Good, up again.
perhaps.
Up again.
Multifocal myoclonus, I agree. Because he kind of has an arm, another arm, trunk, separately, So I would call it multifocal. Would you do it one more time? There's something else I want to point out about this. So not only are they occurring separately and affecting these multiple body parts. Say again? Arrhythmic, sure, yeah. So they're these shock-like or jerk-like movements. So when he puts his arms up in the air, he has more of them than when he's at rest. You see him put his arms down in a second. Sometimes they're bilateral, sometimes they're just one arm.
Good, and put them down
And the
again.
other thing is, here you see, the better when he puts them down. The other thing is sometimes
Good,
he has
up again.
positive
Up again.
myoclonus, and sometimes he has negative myoclonus. Now, I'll tell you that I don't know what this guy has. It's not Tourette's. It's not a bad thing to think about. If you ask him if these he would tell you that these are involuntary. The history didn't sound like Tourette syndrome, but it's a good thought. So so myoclonus, involuntary, brief, jerk-like or shock-like contractions of a muscle or muscle groups that result in a sudden movement. So we can classify them by what we think they're caused by. So there are different types of physiologic myoclonus. So our colleagues in epilepsy see these benign myoclonic movements during sleep, for example, all the time that parents freak out about. So that's a type of physiologic myoclonus. There's something called essential myoclonus, which is supposed to be a benign, isolated, pure, relatively mild kind of myoclonus. The word essential used to be like a pure, like essential tremor. It's supposed to just be tremor all by itself. So essential myoclonus was this relatively benign type of myoclonus. And then there's epileptic myoclonus. So you can have cortical myoclonus that's causing seizures, and they can look like that. And then you can have secondary myoclonus. So that's one way to classify them. And then the other way to classify them is by anatomic origin and by parts of the body involved. So where is that potential being generated? Is it in the cortex? Is it what's been called subcortical, it's been called subcortical traditionally, but it really means brainstem. Is it being generated in the brainstem, or is it being generated in the spine? And as we know, children are much more likely to have genetic disorders, metabolic disorders, malformations that are associated with myoclonus than in our adult colleagues' populations. So when you think about myoclonus, one thing that may be helpful is the farther away you are from the cortex, the simpler it tends to look. That was something that was really helpful for me. So this guy has positive and negative myoclonus that's multifocal. It's pretty complex. Like, the spinal cord isn't really that smart. It's that kind of thing is going to come from the cortex. And if you have, so spinal myoclonus, someone was talking about segmental myoclonus. So spinal myoclonus tends to be segmental or focal. It's just that those myotomes that are innervated by that particular spot. Subcortical myoclonus from the brainstem oftentimes is generalized. So if you have these whole body jerks. Cortical myoclonus may be stimulus sensitive or action induced. So in particular, action induced. So action induced means that it's triggered by movement, or more specifically by sustained posture against gravity. It should really be called postural, but like in Tremor to keep everything the same. But it's action induced. So this guy has action induced myoclonus. It gets worse when he picks his limbs up, and it gets better when he puts them down. So that also sounds cortical. And so cortical myoclonus can be seen on EEG, and it's a prominent feature of myoclonic epilepsies. So one thing that you're going to want to do when you're looking at events like these is you should probably get an EEG. And if you're thinking that they are, if it's one of the progressive myoclonic epilepsies, then you're probably going to want to send them to optho to see if you see any stigmata of those disorders. I mentioned that. Oh, spinal myoclonus also may persist. It's sort of famous for persisting in sleep. So if you see these segmental or focal jerk-like movements, that are, relatively the same every time, and they can be kind of irregular, shock-like or jerk-like movements, and then they stick around when these kids go to sleep, it may be spinal myoclonus. My colleague, Dr. Lotzi over at TCH, detests the phrase, the differential is broad, because it doesn't mean anything at all, and we say it all the time, and differential for everything is broad and all that. But anyhow, there's a huge differential for myoclonus in childhood. So we talked about physiologic and essential myoclonus, and then there are all these traumatic, post-infectious, there's autoimmune etiologies, there's the epilepsies we mentioned, there's these isolated dystonia syndromes like DYT11 that has dystonia and myoclonus that's genetic and relatively pure. And oftentimes, we can see myoclonus as part of a mitochondrial cytopathy. We can see it as part of a lysosomal storage disorder, or the cerebellar ataxia syndromes oftentimes have myoclonus. All right, so this is a 3-year-old male with, so he got sick. He had myalgia and emesis, and then he developed confusion, hallucinations. He couldn't produce speech. Then he became ataxic. Then he had seizures that were recorded on EEG. and then he had some involuntary movements. Anybody, I know we're mostly adult folks here in the room. I see Dr. Clark in the back there. Go ahead and tell, what might this be? Yeah. No? I thought that was a hand. It was just a wave. Could be an autoimmune encephalitis. Might be. Could be an infectious encephalitis, but hallucinations, aphasia, and then all these different things all together, seizures and involuntary movements, we typically think about an autoimmune encephalitis, and we start to work that up. I heard NMDA down in the front. So that is what this guy has.
Okay, buddy, okay.
He was the first recognized case of NMDA treated at TCH. And would you do that one more time? Sorry. Ooh, didn't mean to yell at you. Do you see these mouth movements? Here's these stereotyped, repetitive,
Okay, buddy, okay.
mouth opening and grimacing and chewing movements. He also has some facial grimacing. But very often in NMDA receptor, anti-NMDA receptor encephalitis, we see these oral stereotypies that are very characteristic. So that's what he has. So as you know, so this is it's an autoimmune disorder. We have autoantibodies directed against the NMDA receptor, and we tend to have all these activating symptoms, and we often have, I say classically, but this was the antibody was first discovered in 2007, and the clinical syndrome was first described in 2005. This is a brand new disorder. So typically these kids have any combination of these, but often have all of them, where they become confused, they can have hallucinations, they often have seizures, and then in various types of involuntary movements, often dystonia and chorea and these oral stereotypies. And we treat them with immunomodulating medications, and there's some evidence that suggests that the earlier you recognize and treat these disorders, that they may do better. All right, here's an 11-year-old typically developing male, involuntary movements since age 7. Don't whisper, just tell me. What do we got? Just scream. Tics. I agree with you. You see how these movements look a little bit different from the kid who had myoclonus? These are a little bit more complex, but they can look similar. I mean, oftentimes tics are myoclonic movements, but the history that you get is very different. I'm going to show you this other gentleman with tics as well. He has leg stereotypy disorder, by the way. So he's got lots and lots of leg tics in there. He has headache, neck pain, self-conscious, compare lots of tasks. He's also 14 and 300 pounds. Okay, so some kids have pretty severe tics. So tics are sudden, brief, intermittent, recognizable, repetitive movements and vocalizations. And I know that, so we movement disorders people talk a little funny, but you can see that these different words have different connotations, and the more of them that you put in a row, the better idea that you get of what these things look like. So these movements tend to be the same every time, or very similar, and you may have a whole bunch of different ones, but each one is kind of very predictable in the way that it's acted out, and people can usually hold them in for periods of seconds or maybe minutes, and then, as you know, they're associated with this urge to perform the action. So sometimes I'll explain it as something like, I don't know what it feels like, I don't have tics, but some patients with tics have agreed that it feels kind of like when you have to sneeze, you have that tickle in your nose, and you just cannot go about your business until that sneeze comes out of your face. You know, you guys know what I'm talking about? Okay. So, and it's not a pleasant sensation. You want it gone. So it's something like that. So they're not truly, we call them involuntary movements, but they're not truly involuntary. They're really a response to an uncomfortable urge that happens beforehand, or sensation. And builds up again after they do it. So as I mentioned, first symptoms oftentimes are in school age around 4 to 7. Sometimes we hear about them, 8, 9, 10, 11, 12, but oftentimes if you really dig, one of the most important and useful ways to acquire history that I've learned is to ask parents and children, when was the very, very first time in your life that you have ever had any involuntary movements or sounds? So I ask that question every day. And because they'll come in and they'll tell you, so when he was 14, he started having whatever, lateral neck jerks or arm flinging movements or whatever, and they're uncomfortable and they sound just like tics. But if you dig a little bit, when he was 6, we saw an allergist because he was sniffing and throat clearing all day. But it never really got better with any allergy medicine. So that's a story that kind of thing happens all the time. They tend to have a rostrocaudal gradient, so they tend to start in the face, blinking, sniffing, throat clearing, facial grimacing, shoulder shrugging, and then they tend to move more distally. Everyone thinks, from the movies and stuff, profane gestures, copropraxia, or words, coprolalia, everybody with Tourette syndrome. I think that's probably why parents are freaked out when you make the diagnosis of Tourette syndrome, so I think it's important to tell them that that's not really very common. So we know that this is clearly familial, but we don't know what the gene or genes that are responsible are, despite lots and lots of looking. So there was a study published last year that pointed out that if you look at first-degree relatives, there's almost a 20% chance of tics, but the farther away you get from first-degree relatives, the less it is. So clearly it runs in families, and clearly when you ask families, ask an extended family history, oftentimes you get that kind of history that dad had tics as a child. He had blinking, was never really recognized, whatever. So to make the diagnosis of Tourette syndrome, all you need is this. This is all you need. So it's just 3 little lines here. So you need a year since the first tic started, so that's why it's important to find out when they actually started. You need at least 2 movements, and you need at least 1 sound. That's it. So probably most of the patients that you see who have tics, they probably meet these criteria. I mean, lots and lots of them will anyway. But people are sort of spooked by that diagnosis, and for that reason, some people avoid giving that diagnosis. They just say you have tics or you have a tic disorder or whatever. But I feel it's probably better to just make the diagnosis of Tourette syndrome not so spooky and just tell them that this is all it is. It doesn't mean you're going to shout obscenities at strangers in the bank or whatever. And then in the DSM-5, so this is all per DSM-5, so the other tic disorder diagnoses that we use are provisional tic disorder. So that means you probably have 2 movements and 1 sound, but it's only been going on for 6 or 8 months, so you can't call it Tourette syndrome yet. And then you have persistent motor tic disorder or persistent phonic tic disorder. So you only have movements, but you don't have any sounds, for example. Or you only have sounds, but you don't have any movements, and it's been going on for over a year. This is probably Tourette syndrome. I don't think that there's anything special about movements versus sounds, because the way we make sounds is by moving muscles, right? They're the same thing. So if you have a inhaling or exhaling tic or belching or squeaking, or you're moving your diaphragm, you're moving facial movements, you're moving your tongue. So it's probably a little bit archaic to make that distinction. I do think that the timeline is probably a little bit useful, because once these things have been around for a year, then you can say, well, they're probably going to stick around for a while longer, and that's probably useful because parents know what to expect. We're talking about a prevalence of people about 1% that meet the criteria for Tourette syndrome. There's a 4-to-1 male predominance. So at Tourette camp every year, we've got 4 times as many boys' bunks as girls' bunks. That's true. For a lot of patients, they tend to be at their worst between around 10 to 12. Not always true. There's a lot of it that varies. And we know that they wax and wane and change with time. So I try and explain that to parents so that, every time they eat gluten or red dye or, chocolate or whatever, they don't think that that's the thing that's making their tics worse, because the expectation should be set that these things are going to go like this throughout their childhood and probably into their adolescence. And we know that there are these neurobehavioral comorbidities. So a lot of these kids and family members of these children have OCD and ADHD. And the treatments that we use to treat tics are listed here. So for mild tics, alpha-2 agonists like clonidine oftentimes can be effective. I'd say for the population that I see that makes its way into my clinic, probably 15% or so, 15 to 20% maybe, could do fine with clonidine. And the treatment goal I would always make clear that you're not trying to make them go away. You're just trying to get to the point where they're no longer bothersome to the child. So I usually tell the parents, I don't care what you think, and I don't care what you think. I only care what he thinks. Or I'll tell the kid, your mom's freaked out. I don't care what your mom thinks, and everybody laughs, and it's great, I promise. Topamax sometimes can be effective, also probably around 10, 15% of the time. But sometimes it's all they need, and it's got a beautiful side effect profile, and you can use very small doses, like 100 milligrams a day, once a day. And then if you want to get into the bigger guns, it's the dopamine modulating medications. So I tend to use flufenazine in the D2 blocking class, and I tend to use quite a bit of tetrabenazine, which is a dopamine depleter that decreases the release of dopamine from the presynaptic buton. Botulinum toxin injections sometimes can be helpful particularly if you have a single bothersome tic that's causing neck pain or something like that. You can do targeted Botox injection there, botulinum toxin A injection. You can try cognitive behavioral intervention for tics or CBIT. It's one of the types of habit reversal therapy. There is some data that suggests it works. There was an article published in JAMA, I think in 2010, but also tends to work for kind of a single bothersome tic. So if you have patients that are coming in and saying, their kids have 16 different types of tics, but they don't want to put their child on any medicine, they're probably out of luck. If their kid is saying, these really bother me and I want them to go away, then you should probably treat them with medicine. And then in severe refractory tics, you can use deep brain stimulation of the GPI that can sometimes be really effective. We try not to put them into small children because we know that oftentimes the clinical trajectory is going to be such that they're going to get better by the time they're in their late teens. So if we can avoid putting hardware into their body, we'd rather not. But if they need it and they're medically refractory, then sometimes you just got to do it. Questions for me? All right, thank you very much. Sorry.
Really? No questions? We have 5 minutes. We're right on time, which makes me and some other OCD neurologists pretty happy, I think. I do have one question, and then I'll send you all out, I've seen 2 or 3 what I call status ticanosis type patients.
Status ticanosis.
So severe.
I like it.
By the way, I invented status gelasticus, so if you want to invent that term, please give me some credit.
Of course.
I find trying to treat that as a simple epileptologist very difficult. Do you have any tricks on how to treat those?
So like they have, that's a patient that has lots and lots of tics that
severe, like those you showed us, really
just
severe.
Like boom, and they're happening right now. It's hard. You could try as a and would those kids otherwise, I would think that the majority of the time those kids would probably, it may be the first time, or maybe most of the time it's manageable, but a couple times a month it gets really bothersome or something like that. So I would think that probably the thing to do is to, if they're not on medicine, treat them with medicine, because I don't have a good acute way to knock them down. You can try baclofen, or I don't usually use Klonopin. Sometimes baclofen, if it's causing a lot of pain, neck pain, things like that, you can use baclofen for a few days while I would put that kid on tetrabenazine, like just put him on that. Yeah.
Thank you, doctor. It was a really nice presentation.
Thank you so much.
Minor question. I also I do not practice like physicians, but I'm in the medical science field, and some of the videos that you showed reminded me of some symptoms related to child epilepsy. So maybe I'm wrong, but when you encounter with patients at their first stages, how do you distinguish that it's a movement disorder vis-a-vis a epilepsy-related syndrome?
Sometimes it can be tricky, especially, myoclonus can be really tricky. I think you probably should make sure that those aren't seizures. But I think, there are characteristics in the history and on the exam, if you get to see the movements that are kind of less likely. Seizures don't usually look like action tremor, for example. They don't usually look like tics. They don't usually look like chorea, So there's some differences in the way that they look and by history. Yeah. Thank you.
Epilepsy monitoring. Okay, well, y'all have been so polite and well-behaved. Thank you. I'm going to let us all out 2, 3, 4 minutes early. Let's try and come back on time for 10:15 start. Please try and drag some of your colleagues in here, because the last lecture of the next session, I think it's not well advertised. I didn't know. It's actually about Zika virus predominantly. So please drag some of your adult or child neurology friends. We'll see you by 10:15. Thank you.